in general. I can work this. Okay, so just a little bit of background. South Asia in general remains at a very high risk for disasters, conflicts, and public health emergencies. And just in 2024 alone, over 48 million children needed humanitarian support in South Asia. And the reason I'm focusing on India specifically is because of the diverse range of humanitarian crises that happens, particularly floods, droughts, communal tensions, and displacement crises. And just to give a bit of a background on mental health treatment gap, so just in normal circumstances, there's a 70% treatment gap for mental health services. And that is only exacerbated in climate crises and other humanitarian crises. 15 to 20% of crisis-afflicted individuals experience PTSD and depression, and 3% develop permanent disabilities relating to mental health, where they can't function. And the support that's given is quite minimal. There's 0.3 psychiatrists per 100,000 populations, so around 1 psychiatrist per 330,000, just about. And the global average is 1.3, and the psychologist support is even lower at 0.07. So when we provide mental health care from like urgent response teams or disaster reliefs, these conventional models include a lot of institutional care, which tend to fail in crisis-afflicted regions, especially where there's a lot of heavy stigmatization of mental health already, and the treatment gap is so large because of that. There's also severe shortage of mental health professionals, as I mentioned earlier. And these services, the institutions are primarily set up in urban areas, so they don't reach rural areas where the support is even more needed. And there's a lot of cultural misalignment between what's developed in Western models versus what's required in these culturally diverse areas. So the aims of my scoping review were as follows. So to review what exists in layperson mental health interventions in India, identifying gaps and evaluate adaptability to other humanitarian crisis contexts, assessing what are the implementation barriers and facilitators across different crises, and then recommend scaling strategies for sustainable and culturally appropriate implementation. The methodology was pretty standard, so following the Arksey and O'Malley scoping review methodology, which has been used since 2005 and is pretty standardized. And I searched across the major databases. My initial results yielded around 1,600 articles, out of which only 29 met the final inclusion criteria. And the inclusion criteria was peer-reviewed English publications, interventions delivered by laypersons, so that includes non-medical professionals, Indian population, crises and non-crises contexts, to examine how what's been done in non-crises contexts can be implemented in crises contexts, and also studies that looked at addressing PTSD, depression, stress disorders, and grief therapy. So just to go over the results, I divided the results into 5 major categories. The first one being yoga and traditional interventions. So when I say traditional interventions, they are more indigenous interventions, such as temple healing or yagna therapy, which is a fire ritual traditionally performed in indigenous groups in India. Disaster relief programs, task shifting. So task shifting refers to employing lay counselors in this scenario, so using non-medical professionals. In this case, they're called accredited social activists, so ASHAs, and basically training them in psychosocial support and using them or mobilizing them to give support in crisis-afflicted regions. Digital and technology-based mental health programs, and comprehensive community-based programs, which kind of include education, providing support, and then measuring outcomes of those programs. So the first one is yoga and traditional interventions. So these programs were implemented for about 6 to 7 days to up to 2 weeks for flood and tsunami workers or survivors. And one of the major studies by TELS showed that there was a 60% decrease in sadness and 30% decrease in anxiety. And there were significant improvements in depression, sleep, and autonomic regulation. So these are pretty effective in these in crisis regions because they're very low cost and don't require institutions or infrastructure. Temple healing and yagna therapy also demonstrated cultural acceptability and effectiveness just because they've been traditional practices that have been ongoing for quite some time. However, there are very limited studies on temple healing and yagna therapy, about one each. And some of the advantages of using yoga and traditional interventions, like I mentioned, minimal resources, very little infrastructure that's required, high cultural acceptability, and suitable for crisis contexts where healthcare is also very limited, and leverages already existing practices to deliver mental health support. However, there is a lack of standardization across these methods, which make them harder to implement in a more standardized setting. And because they're implemented for such a short period of time, there's also a lack of long-term outcome data and might not address severe mental health needs where you do need trained specialists and culturally trained facilitators. The second category was disaster response and tsunami relief. So this was one of the major studies that was done post the 2004 Indian Ocean tsunami and scaled over 42,000 individuals and was one of the highest scaled interventions where 800 volunteers were trained in psychosocial support just following the tsunami. And some of the approaches included women's support groups. So teaching women how to sew, how to knit, and do activities that would also generate income post-displacement. Gender-specific interventions for women, for disabled individuals, and play therapy for children was also very effective, especially because children play with other individuals and they really seem to enjoy participating in those. Group counseling for adults and livelihood integration. So one of the key lessons from these studies was that because it trained so many individuals and reached a lot more individuals, there's it shows that you can rapidly mobilize lay counselors in disaster response to reach a large audience. However, because a lot of agencies were employing these interventions, there was kind of a misalignment and lack of standardization similar to previous studies across agencies and inconsistent training approaches across those agencies, which make it hard to collect outcome data as well. And because funding is so rapid in climate context, it's hard to A, supervise this funding, but B, also sustain this funding for a longer period of time to sustain these interventions. And gender-specific approaches, while they address women and children, there needs to be more of this division between what type of women and what type of supports are needed. So that gets me to task shifting and lay counselors. So mobilizing lay counselors in terms of crises response. And there were 3 programs that were particularly successful in doing so: the Manus Trial, Healthy Activity Program, and Atmiyata Program. And these basically show that when you provide lay counselors with the training to give those supports, you can reach a large amount of audience, but also overcome barriers like high caseloads that some specialists or psychiatrists might experience in crisis response. And that also shifts the responsibility on trained facilitators to a more supervisory role as opposed to only giving care. And also the 3 of these programs reached a large number of volunteers and participants. For example, Atmiyata reached over 227 trained volunteers, and all 3 programs showed significant improvement in well-being scores and high community acceptance. And these are the kinds of models that we want to shift to if we want to see a more sustainable approach to mental health care in crises. Digital and technology-based approaches, so smart health, teletraining, and digital platforms. By using similar approaches to task shifting and employing lay counselors, psychiatrists have also been able to kind of use digital training to train lay counselors, which is more effective because that takes a shorter amount of time, and you can mobilize these lay counselors much faster. But also it increases capacity to supervise using phones or smart mental health programs, and similar results as task shifting showed a lot of improvement in depression and anxiety scores over time. And the last category was community-based approach, which is the Vishram program. It stands for Vidaba, stress and mental health response. And this program was quite comprehensive because not only did it engage a lot of people, but it showed that education and removing that stigma is important when you're employing mental health response in crisis settings. So this program reached around 30 villages and around 15,000 people, and showed like 6 key indicators for successful implementation of programs or mental health programs in crisis settings. So community participation, so involving people in the community, which can reduce stigma to mental health or accessing mental health services. Program sustainability beyond initial funding, similar to point I mentioned earlier. Stigma reduction through awareness, resource mobilization from local sources, empowering community members, and organizational competency development. So this also brings the point of standardizing care across different agencies that are mobilizing lay counselors to deliver response. So just going over some of the knowledge gaps, there's a lot of lack of standardized research in these areas, and also lack of outcome data, because a lot of studies will focus on a few weeks or less than 6 months, but we need a longer follow-up period to actually understand the mental health needs, but also if these programs actually have long-term benefit. Fewer comparative effectiveness studies. So do lay counselor studies actually benefit the communities as opposed to specialist trained? Because there is no data on that, it's hard to compare the two. Hard to compare the two, and also lack of research on vulnerable populations, so elderly, religious minorities, and disabilities. Just because there is a heavy stigmatization around mental health care in these crisis contexts, understanding how mental health affects these minority populations is really important, and one of the key knowledge gaps in such studies. And a lot of implementation barriers kind of tie into the financial aspect, because you have lack of supervision of these like initial fundings that are deployed so fast. A lot of funding kind of goes into urgently addressing or like first aid or immediate response, like physical or immediate stress management. It's hard to monitor this funding for long-term mental health response. And like I mentioned, cultural considerations need to look at more minority populations, and especially looking at women, children, and adolescents, perinatal mental health, and elderly and dementia caregivers. Because mental health issues in crisis contexts can compound intergenerationally, there is a huge need to use what's already been done in these contexts, like yoga or traditional interventions, due to their high cultural acceptability, and scale them using lay counselors, lay trained workers to address some of the knowledge gaps. And just to go over some limitations, as every study has limitations, I primarily analyze data in English. So what's already been done might be in different languages that were excluded from the study. There's a lot of gray literature in this context, just because it's hard to classify what people are considering mental health intervention as opposed to just something that they're doing for physical activities, such as in yoga, or just for like peace benefits. There's also a lot of lack of standardization, as I've like mentioned multiple times today. And there's obviously very few crisis-specific studies that include mental health outcomes. And those outcomes, again, they're very short-term outcomes. And there's a lack of follow-up beyond a year. And sustainability is very unclear just because the funding, like I mentioned, is rapidly deployed and not monitored long term. And just my last slide, key takeaways. So looking at task shifting models, there's only 3 major studies that have showed that, but how can we use what's the indigenous methods? How can we use what's already there and use lay people and mobilize them faster? In these contexts will be really important. So including collaborations with local services, local health models, and deploying lay counselors. So we do see effectiveness of community-based programs just because the treatment gap has decreased and the coverage has increased rapidly. And also looking at how technology can facilitate easier mobilization of lay counselors. And some of the future priorities, looking at longer follow-up periods, standardizing outcomes, and developing more crisis-specific responses across agencies. Yeah, so that's that.